Board of Commissioners. Today is November 5th, 2024, and I will welcome everyone who has joined us here in person in Harris Hall, as well as anyone watching online, and to the staff and our administrator with us, good morning. First up, I will check for whether there are any adjustments to the agenda from the administrator. Seeing none, board members, no. I will note we have an 11 a.m. time certain, and quite a few people signed up to give public comments, so we'll be managing time on the fly, and we may end up making some adjustments as we go, depending how time is. Any emergency business from our administrator this morning? None. Then we will move right into public comment. This is the opportunity for members of the public to share up to 3 minutes on any topic that they would like to present before the board this morning. We'll start by going through the list of folks who've signed up here in Harris Hall, and then I'll turn it over to Jessica to see if there's anyone who wishes to present virtually this morning, and then I'll check back to see if anyone arrived late and didn't get a chance to sign up who wishes to speak before us this morning. I will call your name, and when I do, please come to the podium, speak your name into the microphone for the record, and when you do, your 3 minutes will begin. There's, oh, Jessica, can we get the timer up on the wall, please? When you state your name for the record, your 3 minutes time will begin. And so first this morning, I will welcome to the podium Amy Fellows, who will be followed by Jensina Hawkins.
Can you hear me okay? Lane County Board of Commissioners, my name is Amy Fellows. I am one of the 9 members of Oregon's Health Plan Governance Board appointed by our governor that began meeting in April of this year. The Universal Health Plan Governance Board was created from Senate Bill 1089, sponsored by our state senator, James Manning. Our deliverables by September 2026 are to design a comprehensive plan to finance and administer a universal health plan that is responsive to the needs and expectations of the residents of this state. We have just kicked off our 4 committees with members from the public that are consumers of health care from a variety of communities across Oregon. I am the co-chair of the Community Engagement and Communications Committee. 2 of our committee members you will also hear from this morning. The other committees include Finance and Revenue, plan design and expenditure, operations, and later transition and implementation. I applied to be a part of the Universal Health Plan Governance Board as someone with a Master's of Public Health with over 25 years in the field, seeing the devastating health disparities and financial burden our current for-profit system puts on all of us and impacts our most vulnerable family, friends, and neighbors most. United Healthcare, Optum's acquisition of Oregon Medical Group, and the fallout of over 3,000 patients losing their primary care providers is just one example of our current system with incentives to make profits over providing healthcare. I am a disability justice advocate and want to make sure our systems support and do not sacrifice our most vulnerable. I encourage you all to endorse the remitting of the resolution as presented to support our work towards a healthier Oregon. Thank you.
Thank you for your public comment. Next up is Jensina Hawkins, who will be followed by Jay Brown.
I'm a little taller than Amy, but only because I'm in heels. Good morning, Commissioners. I'm Jensina Hawkins, and I've worked in healthcare beginning right here in Eugene since 2006. I've worked in reception, scheduling, surgery scheduling, practice operations, billing, practice management, and compliance. I've also been Council Vice President for the Community Health Centers of Lane County. I'm currently a medical software consultant training over 100 practices in 30 states on utilizing and optimizing their electronic medical record system. Over the years, I've had a front row seat to the all-consuming financial struggles of medical providers who want to render equal care to all patients, but the reimbursement they receive from various payers is wildly unequal. I've had the heart-wrenching task of building schedules to allow only 1 or 2 low-paying Medicaid patients per week in an effort to accommodate more high-paying Blue Cross and commercial Pacific Source patients. One evening about a decade ago, I was at the Riverbend ER with a sick child, and the frantic mother next to me repeatedly told the desk clerk, "We have Pacific Source. We should get to move ahead on the line because our insurance will actually pay you." I don't condone her request for favorable treatment based on financial status, but the tragedy of the story was that she was not entirely inaccurate. A couple of months ago, a couple of you generously helped support this first citywide healthcare forum, which I organized and moderated. That evening culminated in a total of 77 questions received from community members for our panel of elected and appointed officials. One of the most recurring themes in those questions was folks asking how to find a provider who accepts their insurance. There were many harrowing, heartbreaking tales of senior citizens who purchased a Medicare Advantage plan based on slick promises that nearly everybody accepts this plan, and yet they discovered that in fact nearly nobody accepted their plan. It's my honor to be on the Community Engagement and Communications Committee for the Universal Health Plan Governance Board, and I'm here to request your support for the amazing work being done to ensure every Oregonian has equitable access to quality health care.
Thank you for your public comment. Next up is Jay Brown, who will be followed by Tom Peck.
I feel like we're about the same height, so that works out great. Good morning, good morning. So I want to take a moment to express my strong support for the resolution backing the Universal Plan Governance Board. As a single income mother, former foster mother, youth advocate, and social worker of 16 years, I witnessed firsthand how vital it is for everyone to have access to quality health care. This access isn't just about individual health, it's about the well-being for our entire community. When all of us have proper health care, we can see fewer illnesses spreading, and our children, peers, friends, and family are successful in pursuing and living healthy lives. This benefits not only the families, but our entire community. The current healthcare system can feel overwhelming and very costly, not to mention overly exhausting to navigate, often leaving our health departments strained. By moving towards a public-funded universal health plan, we can shift our focus from complicated billing to providing real care for our community, one that focuses solely on the well-being and outcome of health over the dollar amount, codes, and paperwork process. Every individual, every heartbeat, every brain, everybody deserves quality care. A mother should not have to choose between a doctor visit for their sick child and putting food on their dinner table. A couple shouldn't fear bringing a child into the world due to the costs associated with birth of a child. It's more expensive the entire first year, 3 years of the child's life than it is to just have the child at a hospital. This change would help us spend more time helping people and less time on navigating paperwork that appears to be never enough anyways, depending on your CCO. It's a top priority to address the social factors that affects health as well. Investing in these areas can lead to better outcomes, especially for communities that have faced historical inequalities, biases, or blunt disregard, as if they do not have the right to live a healthy life. The steps already taken in SB 770 and SJR 12 shows that Oregon is committed to making a healthcare right for all, and I really appreciate that, right? Supporting the governance board is a key part to making that vision a reality. We have already set the bar really high in Oregon. Again, appreciate that, but let's continue that. It's a place where people seek safety and community-focused environments. Let's continue that trend, continue to build a state that is affirming the commitment that you matter and we care about you. Due to the CCO, service providers, and strict guidelines, even if someone does have insurance, the access is very limited depending on their provider. A good example was the Trillium Pacific Source situation. This is unacceptable. We're seeing an increase in preventative healthcare concerns spiraling out of control due to the insurance hinders. Perfect. I'll just skip down because let me tell you, I had a lot to say. I strongly encourage the commission to really push the governance board. We really have a great plan. I think we can really do some great work out here, so I appreciate you.
Thank you for your public comment. And I will just note, anyone is also welcome to email your comments to us, particularly if you don't get through them in your 3 minutes. Next up is Tom Peck, who will be followed by Terry Parker.
Good morning, Commissioners. My name is Tom Peck. I live in the Friendly Neighborhood and on the Friendly Neighborhood Board. I would like to talk to you this morning about the corporatization of our healthcare. 30 years ago, physicians, for the most part, were self-employed, but today, 80% of our physicians are employed by large corporate healthcare systems, private equity firms, and insurance companies. The Eugene and Oregon are a prime target for the purchase of our healthcare systems. The acquisition of Oregon's healthcare clinics has increased 100,000% in the last 10 years. Corporate executives are making decisions about our patient care, but remember, corporate executives have a fiduciary responsibility to their shareholders to make a profit. Physicians, however, are held to the Hippocratic Oath, which obligates them to the patients, for their patients. This conflict of corporate versus physicians' interest is the cause of the Oregon Medical Group's meltdown. We are losing primary care, community-based healthcare clinics, pushing more and more patients into extreme long waiting lines at our 2 emergency rooms in Springfield. It has been proven that that basic primary care keeps patients out of the hospital and increases their likelihood of recovery. I think the closure of the University District ED, Peace Health, shows that we are moving in the wrong direction. I have an example, a personal quick story, that I had a medical emergency recently. I was transported to Peace Health Riverbend ED. I was discharged in 3 days with a long list of medications with no explanation of the side effects, and I was told I'll talk to my doctor in 3 weeks. However, I am a patient of Lane County Public Health. Then 2 days after I got home, I got several calls from Lane County staff saying, do you need food? Do you need care? Do you need to make an appointment with your primary care physician? That's the kind of care that we get from community-based. So I have a few suggestions, resolutions.
Mr. Park, I'm sorry, your time has expired. We would love it if you would please email the rest of your comments to us. Thank you so much. Thank you for your public comment. Next up is Terry Parker, who will be followed by Raudel Peretschitze. Please correct my pronunciation when you get to the dais.
Great. My name is Terry Parker, and I'm here as the president of the League of Women Voters of Lane County. The League is a political grassroots network and membership organization that believes that the freedom to vote is a nonpartisan issue. Today is a good day for democracy, and that is demonstrated by every single person in this room, including yourselves, and I want to thank you for doing the work that you do. The League of Women Voters stands on the belief that the U.S. healthcare system should provide all U.S. residents with a basic level of healthcare. Basic care includes disease prevention, primary care, including prenatal and reproductive health, acute and long-term care, mental health care, and health promotion and education. Healthcare policy goals should include the equitable distribution of services and delivery of care, advancement of medical research and technology, and a reasonable total cost. So I want to make this short because you've got other people that want to say, do what Tom said, you know. Tom had it right. Pursuing this dream for Oregonians is vital for the overall health of our communities. We ask that the board endorse the resolution in front of you presented by your Department of Health and Human Services. We've seen our own community the negative impact of the trend of consolidating healthcare markets, with insurance companies and private equity funds making acquisitions in many healthcare arenas that result in spiraling prices, diminished access, and declining quality, including unnecessarily illness, injury, and death. The United States already trails peer nations in the quality and outcomes produced by its healthcare system, while simultaneously leading the world in the cost of its care. We should be hyper-focused on moving in a different direction. Thank you.
Thank you. Next up is Raudel. Thank you. Please welcome to the podium. Please state your full name for the record. And again, my apologies for mispronunciations. And you will be followed by David Eigel.
Okay. Good morning, Lane County Commissioners. My name is Raul Perez-Chica. I am Healthcare for All Oregon. I hope you will adopt the resolution in support of, excuse me for a minute, when I put my glasses on. I'm getting older. Let me start over. I hope you will adopt the resolution in support of publicly financed universal health care. A universal health care system will help essential workers like the farm workers, which help harvest our crops in Lane County. This will go a long way in helping farm workers and their families stay healthy and productive. This will also help other minimum wage workers to keep more of their hard-earned money and will go toward other expenses. It is in our interest that essential workers stay healthy as they contribute to the local economy. Thank you so much. Have a good morning.
Thank you for your public comment. Next up is David Eigel, who will be followed by Dr. Henry Elder.
Good morning, everyone. David Eigel. There's a great deal of political friction today. I've been assured that if Donald Trump wins the election, democracy is at an end, and I've also been assured if Kamala Harris wins the election, democracy is an end, but I don't think either statement's true. Fortunately, there is one topic that we can all agree on, honoring the late Professor Frederick Dunn. This scholar of outstanding ability, a real gentleman, kind and caring, widely beloved and respected in this community. He was the product of one of the most heroic abolitionist families in America. He was ecumenical. In 2016, due to U of O President Shills playing sleazy campus politics, this great man and this community's reputations were smeared. The U of O trustees have the authority to name and dename buildings. They have no monopoly on historical narratives, and their narrative has been completely discredited. It's not only wrong, it was established by use of fraudulent information. With this in mind, I'm asking the commissioners to take action. And it doesn't have, you don't have to spend any money, even a public declaration on honoring this fine man. And if you need some money, I can certainly come up with some for plaques, et cetera. So with this in mind, I'm asking you at this late date to finally take affirmative action, and let's clean up our history with regard to this very fine man. Again, I ask for your actions on this matter.
For your public comment. Next up is Dr. Henry Elder, who will be followed by Hap Honodell.
Hello, I am Dr. Henry Elder. I am a retired psychiatrist and practiced for 45 years in family medicine and psychiatry, ending in Eugene 2 years ago. During the time that I practiced, it was clear that medicine was becoming more and more pressured by the presence of and action of insurance companies, and it has been progressively worse. I am here to ask for your support of the resolution in front of you because I believe that removing the insurance companies from the impediment to medical care will vastly improve the services in Lane County, especially to mental health patients. Because mental health patients have much more difficulty adjusting to the demands of insurance, and because doctors do not enjoy the battles that they have to, that are imposed upon them by insurance companies, the removal of those battles would vastly improve care to everyone, and that includes my partner, who is just minutes ago we had a conversation about a difficulty that she was having. She's an internist who shares my beliefs that medicine is deteriorating and has a difficulty that she wants to attend to. And we discussed it this morning. She said, I'm not going to be able to see the doctor for a month. Anything I would try to do would not, even though she's quite capable of understanding what is urgent and what is not, she is unable to get medical care for a month. And this is outrageous that is widespread that people who do not have the training of the physicians, who do not have the experience, the practical experience, become gatekeepers to determine whether people get care or not. I ask you, please, to consider the advantages to the people of Lane County of supporting this measure and the major efforts that the Oregon has to become the forefront and the promoter of better care for everyone. Thank you.
Thank you for your public comment. Next up is Hap Honodell, who will be followed by Charlie Swanson.
Good morning, Commissioners. Thank you for the opportunity to speak. I just want to remind everybody in this room that we have all had a universal health care moment, and that was when the federal government offered the opportunity to get the COVID vaccine, which was delivered literally through the windows of our cars. That made the entire population of the county, those who took part, a much healthier population, and we know that a healthier population is more productive and gets more work done in our country. I want to just encourage you to adopt or support the resolution for presentation to the Oregon Universal Health Governance Board. I think this would be a good move for our society, and certainly the voters of Oregon have indicated that they are interested in having health care be a human right. So it sort of means we all have to work on that together. Thank you.
Thank you for your public comment. Next up is Charlie Swanson, who will be followed by Lou Sininger.
Hello, I'm Charlie Swanson. I'm here to support the resolution in favor of the governance board, or supporting the governance board. I am a member of the Finance and Revenue Committee of that governance board, and one of the things I want to emphasize is the last couple clauses in the resolution about Lane County helping the governance board so that it, as the plan develops, it will meet the needs of Lane County and Lane County residents. And thank you.
Thank you for your public comment. Lou Sinninger is the last person I have signed up in Harris Hall, and then we'll turn it over to see if there's anyone wishing to present online this morning.
Good morning. I thank you very much for listening and having this this thing well organized like this, and I appreciate the commissioner's work on these problems. So my name is Lou Sinninger, and I live out in Elmira, so I'm a rural resident. However, most of my life, my career, was as a union rep. In fact, I worked 20 years for AFSCME, and one of the locals that I was responsible for was Local 2831. And so I have kind of an inside view of how insurance, health insurance, has become kind of the elephant in the middle of the bargaining table. So what I saw during my years of experience was that the insurance, the cost of it always went up every year, and the benefits were somewhat reduced. So what this does is create a burden. It's a burden for Lane County as an organization, and it's a burden on the employees. Stop to think about the number of people that you have working just to administer health insurance. And stop and think how much it costs the Health and Human Services Department just to administer the care through the health insurance companies. So I got to thinking, there's got to be a better way. And it started with the passage of Senate Bill 1089, which creates the Universal Health Plan Governance Board. It's a big step forward to try to find a better way. So I ask you to support the resolution in front of you. And I think by seeking a better way, we will all get better soon, okay? Thank you.
Thank you for your public comment. At this time, I will turn it over to Jessica to manage any online queue. Jessica, is there anyone wishing to give public comment to the board virtually this morning?
If you would like to give public comment at the Board of County Commissioners meeting for November 5th, please raise your virtual hand. I see no hands raised. I will return the meeting to you, Chair.
Thank you, Jessica. Is there anyone else in Harris Hall who didn't get a chance to sign in who wishes to speak? Seeing none, I will close public comment. Thank you all so much for coming, and turn it over to the board for any response to public comment or other remonstrance this morning to the board. Vice Chair.
People are being quiet today. I'll tip it off. Thank you for all coming. It's been a great morning so far. Obviously, it's a great day to have public comment and governance and things that you want us to do. It's because it's election day, so it's a good season for that. But more importantly, I think hearing your comments about the healthcare system is deteriorating, I would agree with that. And obviously, all of us have stories of difficulties we have and waits in emergency rooms and waits to get appointments and all that. And so I'm excited to have the discussion going forward. And I, again, appreciate you all for coming out and alerting us to your concerns as well. So thank you again.
Commissioner Senega.
Yes, I'll start by quoting Ms. Parker out there. Today is a great day for democracy. Thank you for that this morning, because that's how I started my day with my kids, as I was explaining to them what an important day today is. And regardless, we will all be all right. Thank you for showing up today. It's a perfect example of that. We're going to get into some great topics later on, and I'll save most of my comment for that. Thank you. Appreciate it.
Right.
Okay.
Commissioner Farr.
I'm going to toss a coin. Well, thanks for being here this morning. And Jensina Hawkins, I'm going to single you out. Thank you for being here. And thank you especially for your service on our Lane County Community Health Council, not to be confused with the Lane Community Health Council, which is something very different. Thank you for your service there and your continued focus on really, as you mentioned, a broad attention to healthcare in Lane County. You have a great deal of experience, and the experience that you have cited and the others in the room here help us all to think more clearly about what it is that we're going to be talking about today. Especially, you know, we all have experiences, and rather than take time during the when we have a presentation, I'll mention while you're here that I have a constituent who is a cancer survivor who recently began experiencing bleeding, extensive bleeding. And I went to see doctors and is unable to get attention and care for about 60 days. And that person was told that, well, you're lucky to get it that quickly. I think that's what we're talking about here today, isn't it? About the care that people need, getting it when they need it, and in a fashion that they can continue to meet their other obligations. You know, no matter how sick each of us are, or no matter how much care we need, we still have other obligations to our family, to the people we work with, etc. So I love the presentation you made today. It gives me a chance to think very, very clearly, not about what we're talking about today, but about the people that we're talking about today. Thank you. I'll mention also, Chair, the doors are closed across the street. I think the farmers market's done for the year.
Tuesday market for sure is. Commissioner Buck, did you want to weigh in this morning?
Sure. Thank you, Chair. Thank you, everybody, for showing up for healthcare. It is not necessarily my professional background. I am learning a lot every time that I go to a fabulous healthcare forum, let's say. Ms. Hawkins, thank you for that. Or when I talk to other medical professionals, I'm learning so much about the corporatization of our healthcare system and how it's really breaking the system in general. And we do need a new way forward. And I appreciate your volunteer work on the governance board. People could be doing a lot of other things with their lives, but when you step up with the knowledge and expertise, that only helps us as a community. I certainly have support for this resolution and your work going forward, so you can count on that. And if I can be more helpful, please feel free to reach out to me anytime. And I'm willing to meet, talk, show up to functions, however it is most useful and proactive. I also wanted to take a separate moment to provide the board with an update from our previous meeting regarding the Blue River Design and Transportation Growth Management Plan. We took action last week to implement that plan, but it was clear that there were still some concerns regarding parking. And so I've delved into this with our fabulous Becky Taylor, who has been very involved in this project. And there were two concerns, specifically regarding just generalization of additional parking that may be needed and how that might be accommodated. And then as people build, if they are required, if they want to have parking, are they required to have ADA parking before the road is developed? And without the road being developed, it's like a catch-22, there's no ADA parking for them to develop. So we've been working over the past week on those two specific issues. Given that there is no parking requirement, they don't need to make an ADA spot if there's no parking requirement. However, if they do want parking, that's a different issue. And without the road being developed in downtown Blue River, that might be a catch-22. So we are going to work specifically on that particular issue. And, you know, regarding the parking supply, the design that Becky has created really looked at every possible configuration to get as many parking spaces as possible. We're confident that the plan that we approved last week did that. But to accommodate any additional parking, what is likely going to need to develop is a separate project for some parking at a location, maybe where LTD stops, or maybe another spot where there might be a gas station or an EV hookup or something like that to accommodate any additional parking needs, so that when businesses want to redevelop in Blue River, they have that opportunity and the parking can be accommodated. So I just wanted to assure us that the plan that we had in front of us last week was good, and it was proper for us to approve it at that time. But as there is in all things in recovery, after a mega fire, not every plan is foolproof, and there's always additional projects to work on. So I made it a priority in my work to continue that work with Becky and with constituents in Blue River. Thank you, Chair.
Thank you, Commissioner. Well, I'll just echo everyone's appreciation to all of you for coming this morning, particularly on a Tuesday morning, and particularly on a Tuesday morning at which we are all potentially a bit distracted. So thank you so much for taking time to come here and talk about this really important equity issue around healthcare delivery. And I'm just always struck how we as a society have become so used to using healthcare when what we mean is health insurance. Oh, you have healthcare through your job. No, I have health insurance. That doesn't mean I have health care. And that is really what this governance board is going to look at, is how to set up a state where everybody actually has care. And that is of utmost importance, I think, to everyone who spoke, and from the comments you heard here, I think from my colleagues and certainly for me. I invite you all to stay if you'd like. I know folks have often other things to do. Speaking of care, maybe people to care for or other work to get to, but our next item, we will now convene jointly as the Board of Health and the Board of Commissioners to move into our Health and Human Services items. And the second of these items is the resolution that many of you showed up this morning to speak to. But first, we have our semi-annual Board of Health report. And so I will welcome to the table Dr. Jocelyn Warren, our Public Health Administrator. Oh, sorry. Oh, sure, okay.
I didn't mean to interrupt you, but
I did say someone's distracted. I didn't say who.
On the fly there, I thought we were rearranging something.
So before we move into our Board of Health report, thank you. I will look for a motion to approve today's consent calendar. These are all items considered routine. If a commissioner wanted to discuss one, we would have pulled it from the consent calendar, and all the materials that we have to review are available to you online on today's agenda. So with that, I'll look for a motion.
Chair, I move to adopt and approve the consent calendar for Tuesday, November 5th, 2024.
Thank you.
I'll second.
Thank you. It's been moved by the Vice Chair and seconded by Commissioner Buck to approve today's consent calendar. All those in favor, please signify with an aye.
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 Motion carries 5-0. Thank you. And now,
we're just so excited to get
I was so excited to get to the Board of Health. It's actually, that's not untrue. So I will welcome Dr. Warren to the table, introduce anyone you've brought with you this morning, and turn it over to you for our semi-annual Board of Health report.
Thank you, Chair Trieger and Commissioners. We're happy to be with you here today. Today I've brought Nicole Sticka, who's our nursing supervisor for our communicable disease program. Nicole is going to provide an update on both measles and pertussis as and those respiratory infections continue to circulate in Oregon. talk a little bit about our situation here in Lane County. As a reminder, this is part of our semi-annual public health report. We've also added 2 additional reports coming out of COVID, and we will, after Nicole has her presentation, have another proposal potentially for revising that schedule a little bit, just as we come into a new cadence, coming out of more fully of our COVID response. So I'm going to pull up our presentation and turn it over to our nursing supervisor, Nicole.
Good morning, commissioners. So for the sake of time, I'm going to move through the slides pretty quickly, so that way we make sure that everybody has time to present today. And then have enough questions or time afterwards for questions. Thanks, Cameron. So just talking about, as Jocelyn had said about the immunization program, giving just some quick updates about where we're at with our immunization program at the communicable disease. As you know, with our department, we do other things besides just vaccinations, but this is a huge part of one of our programs that we are actively involved in, and continuing to see where it is that we can engage with the community and make improvements. So. So we're going to.
Excuse me, Nicole. If you could if you slide your laptop and mic over, then the mic is more. It doesn't need to be closer to you this way, but just that way. Perfect.
Is that good?
Yeah, I think Metro is.
Oh, I can. That is better.
Better here. Better here. Thank you.
Thank you. So starting with talking about measles and why. We start with measles, and the best way I can put this is because the knowledge of measles can provide valuable insights into the overall resilience of a community's health infrastructure and its ability to prevent and control other vaccine-preventable diseases. So we're going to talk about measles. I'm just going to do a quick run through of what measles is and the concerns about measles, and then some of the data around that. I'm also going to go into what we saw with our pertussis outbreak that we actually still are in. We have not moved away from the pertussis outbreak. And we are still learning about some of the ways that we can be improving in our response to outbreaks by what we learned from pertussis. And then just a quick bit of information regarding NACCHO's immunization profile study for 2023 for the U.S. and some of the data that was gathered that is relevant and comes in alignment with what it is that we feel like we also see with the immunization program. And then what our plans are over the next year or two to help improve vaccine uptake in our community. So starting with measles, I think, just a quick overview of the disease is some of the signs and symptoms of the measles virus, an acute febrile rash, fever, cough, runny nose, conjunctivitis, which has to do with the in the eyes, inflammation of the eyes, transmitted by direct contact with infectious droplets or airborne route. The main thing that I feel like we don't understand, because we don't see it as often as what we had in the past before vaccines, but we are starting to see more and more of measles in the U.S. and in Oregon, is the level of infectiousness of measles. It is one of the most highly contagious infectious diseases that we have. And in case when we look at what we call an R-naught, which is the RO, basically is just a way to be able to define how contagious a disease is. And with measles, basically, the R-naught is 12 to 16. I've seen some where it says 12 to 18. And that just has to do with how many people one person who's sick can infect. And so to give a guidance on what that is, in case you're not familiar with R-naught, is the typical flu virus and COVID viruses are anywhere from 1 to 3 people that it infects. And so measles is 12 to 16. Pertussis is also really high. It's up there with measles as far as the level of infectiousness. So we have major concerns when we have an outbreak. It means that because it's so highly contagious, a lot of people have the potential of being affected by it. And so there is a lot more concern when we have a measles outbreak. And then also just going over a quick incubation period, so just how long it is that somebody can be contagious or infectious during the time that they have measles. So this gives us a guidance for when you typically will see symptoms, and then what that infectious period is, because it's the guideline that we utilize for if we have somebody who is infected, how long would they have to stay in isolation? And it's typically 21 days, which can be a really long time period. So when you have a kiddo who has to stay home for 21 days in isolation, the effect of what that can mean for a family is significant. So you also see these, in case anybody's interested, trying to be techie, you see the QR code. I decided to put a QR code up there for my references for my slides. So if anybody is interested in getting quick access to where it is that this information was pulled from, that's a good way to do that. So measles complications. So typically for hospitalization, it's about 20%. And then some of the other things that you can see that are connected with measles complications. Including encephalitis, which is very concerning, and death, 1 to 3 per 1,000 cases. And then the subacute sclerosing panencephalitis, I actually had to look that up. And sometimes, that can lead to other things. Then you go, oh, wow, that's actually pretty serious. So 1 in 100,000 cases, so it's rare, it's not common, but it is something that is an interesting part of measles that can happen to a person, mostly a child, about 8 to 11 years after they actually recover from measles, where this is something that can come up. And the mortality rate for it is 95%. So it's rare, but it's something that can happen. And, it's something that reminds me of what we saw with COVID and what we see with other viruses, which is, typically most people or most children, they get it, they clear it out of their system, and we move on. They go in isolation and move on. But, and we saw a lot of that with other viruses. But there is always that possibility that you have somebody who is affected in a different way, and we don't know who those people are going to be. A lot of times it's our immunocompromised populations, but we don't know who that is going to be when we have people who are affected down the line, or what the long-term consequences are. And so I think it's just good to note that measles is one of those viruses that isn't just something that comes and goes and is cleared out. There is a potential for long-term health effects or comorbidities related to measles. And even though it's rare, it still is something that can happen. And so I feel like this is something that is necessary to point out with measles as we take a look at this. Another aspect of measles too that has been something I've done some research on and squirreled and gathered a lot of information. And if you use some of the resources there and even look this up, you will find that there's all kinds of interesting studies that and historical references when it comes to what we call measles amnesia. So this is a quote from the American Society of Microbiology, just to kind of put an emphasis on the dangerousness or the impact that measles can have is often overlooked. And one of the things that we look at is immune memory from previous infections, the ability of measles to destroy immunological memory and replace memory lymphocytes. And that is something that's unique to the measles virus. We don't see that with other viruses. And there's all kinds of statistics out there about how it is that this looks for an unvaccinated child that gets measles, and what the statistics are for how much of their immune system, their natural immune system from other pathogens becomes erased because of getting measles. And it's anywhere from 11 to 73%. And that's another thing that runs on a scale depending on the child's other health conditions and other things that are those social determinants of health, or like what we were even talking today about the impact, long-term impact of the health of our children and of our families. So when you look at measles-induced amnesia, this is just a quick look and not anything that I felt like we needed to get too far into the weeds about. I tried to keep it as basic as possible because it gets very sciencey, and then it's hard to really be able to communicate what this looks like. But basically, when you get exposed to measles virus, it enters the lungs, it replicates in the lymph nodes. It then can cause elimination, or I gotta go down, infects the memory T and B cells. That's where we have the memory cells and the naive T cells that are involved with our immune system. That's our immune system that's responding. And then the body works to clear out the virus. What it also does is it clears out all of the infected cells and has the ability to erase and also remove some of those cells that hold the memory for other pathogens that the child, if we're going to focus on children that are most affected by measles, is hanging on to. So what that can do then is make that child more at risk for getting a secondary infection as a result of the measles eliminating a child's ability to defend themselves from everything, even other vaccines that they might have had, or other pathogens they had been exposed to. So when we look at this, just really quickly, some of the numbers I looked at, it can take 2 to 5 years for then a child to bring their immune system back up to full immunity. There are some numbers and statistics out there in some of the studies that show that 11 to 73% range for elimination of some of their memory of their immune system. And that in historical context before vaccines, they were able to discover this measles amnesia through other studies that they did to look up the numbers of children that died from secondary infections after measles because of this erasing of the immune system. And so there are some numbers behind that, that it isn't even measles-related deaths, but deaths that are related to infections secondary to that. So it's interesting. So not to continue down that path, but just something that I think is really an interesting aspect of measles that doesn't get talked about very often. And then the highest risk of concern for measles complications, of course, is for people who don't have evidence of immunity, who have, and those who are exposed at higher risk are, of course, our infants less than 1 year, pregnant people, and then people with immunocompromising conditions, or if they're taking medications that compromise their immune system. So if we look at data for what we looked at for outbreaks in the U.S., this is just a quick look at the increases that we're seeing. In one of the reports that I had looked at, they had, from the National Institutes of Health, had stated that since 2018 in the U.S., we've seen a 300% increase in measles cases in the U.S. So that is a significant impact to many people. So there's also this slide that I think is really important to point out, that the higher number of cases that we see that are in the U.S. are more typically for measles that are a result of a U.S. citizen going out of the country and coming back with measles is basically what that is. So the purple section shows that it's U.S. resident related, and the gray is related to foreign visitors. And just to point out the importance of that it's actually U.S. residents that are more typically bringing this back from other countries and then infecting and causing the spread of measles more than asylum seekers bringing them in or anyone from other countries bringing it into our country. It is U.S. citizens that actually bring it back. So. And then looking at just kind of a look of what that has looked like. This is as of October 17th, 2024, and just a quick look at the color coding of which states had the biggest impact for measles outbreaks and the lower impact. So just a quick visual on that. And then just the numbers that go with that. So total cases still in that same time period were about 269. As you can see, a significant number of them were for kids under the age of 5, and 88% of the cases were unvaccinated. 40% of them ended up being hospitalized as a result. And then Oregon measles data for what we saw for just this year. So we saw 31 total, and those are the counties that saw that. As you can see, Marion County got hit pretty hard with that, and that the age ranges for that and the numbers are pretty similar to what we see in the U.S. So unvaccinated children. And so, of course, the number one control measure for the best prevention of disease is vaccinations. You know, measles, MMR has been a licensed vaccine since 1971. We were able to eliminate measles from the U.S. in 2000. It was only for a very short time period, but we were able to do that. And it is highly effective vaccine. So that's the other thing to note with measles is it's very robust and has great protection even with just one dose. The second dose gives a little bit more, but as you can see, even one dose has a 93% effective rate for it. Routinely, vaccinations are given at the age of 12 months and then again at 4 years of age. So there's a pretty big time frame there where before a child is fully protected from measles, because they actually don't have the second dose until they hit the age of 4 or 5 and go to school or go to kindergarten. So yeah, there's just some information on that. I'm just going to scroll down on my notes here and make sure that I'm not missing anything. Okay, so national and state level 2-dose MMR coverage. So this just gives us a look at where we're at in the U.S. as far as 2023 for our coverage rates, and then color codes it where we're at. And then I was able to pull this from the Oregon Health Authority, the Oregon Immunization Program that was updated in March of 2024 as far as how many kids younger than school age are up to date on their vaccinations in Lane County and UT MMR. We're at 90%. Which is below what is the recommended rate for full protection with measles. So, but if you look at that next slide right there, you'll see that it goes up a little bit when we talk about the older age group, kindergarten through 12th grade. It goes up a little bit. So that's good news, and that's a little bit higher, actually, because I want to be able to focus on good news. It's a little bit higher than what it was coming out of COVID, and coming out of COVID, we were actually pretty low, and it made us all a little bit nervous about what was going to be possibly hitting us, especially when we're seeing a pertussis outbreak that we're still managing, and the potential for measles to be in this state, and then how close it got to Lane County. So it's good to see that we have a little bit better protection once we hit kindergarten through 12th grade. It still doesn't meet the mark for full herd immunity, but it is better. So that's good. And then this is just a quick look at, I just found this was interesting. I got this from a site that was, that does the modeling for what it would look like for a 6-month-old, if we focused on this age group for an outbreak, if we were only covered at 80%, which we're higher than that, but if we were covered only at 80%. And I think that if you push, so this is what it would look like if we were to see an outbreak in Lane County. You see the little red dots, and this just gives you a modeling. When it turns blue, it means it's signifies a recovery, but how quickly and at 80% level that can spread into our county. And I believe they take that into like a 6-month time period. And then versus the next one over, which is at a 95% coverage. So we have full coverage of measles. It looks a lot better when we have a higher level of coverage. And that's significant for when we talk about how many little kiddos and families would be affected by such an outbreak as that one. So. And so then switching over to pertussis, and just a quick, real quick look at where we're at with pertussis. These numbers were updated as of October 25th. This is some of the data that our epidemiologist, Catherine, was able to update and graph for me. So this just looks at what we've been kind of dealing with since February when it first started, and that, like I said, we're still in this. We're still getting reports every day of pertussis cases. So, and a lot of them seem over the last couple of weeks have been younger. younger than the age of 5. We've even seen some under the age of 1, which is really concerning, and then also some pregnant people as a result of some of this outbreak. So just looking at some demographic information about what we typically will have seen until October 25th. So as you see, the age between 5 and 18 is the typical, and then some of the race and ethnicity groups that we have that are most affected. And then just a week by week look at that, comparing 2018, which is the last time we had a pertussis outbreak, and what the one that we're in right now. So, and how you can see that there's a little bit of some differences there. So. And just some of the things that we've learned so far from the pertussis outbreak is that we have lack of resources during the peak of outbreak. So when we were really in the middle of it, is just being able to pull resources. I also noticed that when it said HON alerts being shared, I meant that should be say ineffectively, not effectively. They were actually not very effectively shared, and so that is something we're working on, trying to see how we can improve our HON alerts that go out. Insufficient testing, lag times in reporting, incorrect treatment and recommendations, and lack of knowledge of pertussis disease pathology are some of the barriers that we have found dealing with the pertussis outbreak and that we're still seeing. So,
Nicole, it looks like you have about 4 more slides, and I do want to make sure we leave time for any commissioners' response or questions, and we do have a few other items coming up.
What's my time at?
We're
never seems like it's
pretty much there.
That long. Thank you. Yeah. So these, so the rest of these just have to do with this analysis from NACCHO regarding our immunization profile for in the U.S. and the data that they gathered from 336 other local health departments in the U.S. about, you know, what are some of the things that we are all seeing. And I feel like we could say that these are the things that we also can relate to about the difficulties and the successes that we have when it comes to our immunization activities in our community. So I don't have to read them to you. You have access to them, but I just find that it's interesting to see. Also, I'd like to just, you know, what we are commonly seeing is the hesitancy or lack of confidence among patients and parents when it comes to vaccines. That seems to be a pretty significant barrier. And limited or insufficient staffing is also something that we seem to be constantly trying to figure out ways to overcome when it comes to our ability to respond and meet the needs of the community for prevention. And then just some collaboratives and coalitions that other health departments try to work on, and these are all also part of our plan of where we are trying to build better partnerships and connections in the community to try to beef up our immunization numbers. So this is just some of the stuff from our work plan, our Immunization 43 grant that we have, or program element 43, which has to do with our immunization, and the funding, the small amount of funding, very small amount of funding that we have to try to go out and do some of this work that we're going to be doing over the next year or two to be out in the community more outreach effort, more partnerships, conducting surveys to get a little bit more an idea of why it is that there is hesitancy, why there are those that are vaccine averse, and see if there's something that we can do better in making sure that we're meeting that need. Is it an access issue? Is it a trust issue? So, yeah. And then there's all my resources. And there we go. Thank you.
Great. Thank you so much.
You're welcome.
And Jocelyn, were you thinking just a couple of minutes for any commissioner questions or response around the immunization presentation?
That would be great. Yeah, and then
you
we can
wanted
move to the proposal.
do a little
Thank you, Chair
bit of business with us. Great. Well, then to the board, any questions or comments for Nicole? Commissioner Buck.
Thank you, Chair. What is a HON report? I don't know what HON is, or not a HON report, a HON alert.
Yeah, that is a health alert. It is a way that we notify, especially providers, regarding any type of an incident that we think that they need to be aware of. The CDC puts out HON alerts too, so I'll typically get them from the CDC, but we also send out HON alerts. And it's just whenever it is that we see something that we want our providers in our community to be aware of, that we are seeing, and we feel like they need to know that we maybe see an outbreak of something, or we want them to be aware of something that's in our community that they need to have on their radar. So if they are treating people, they know to be looking for.
So this would likely be an email to pediatricians and whatnot, and just say, hey, we're seeing a lot of these cases, but not necessarily to residents.
Right. We send them out to providers, but we typically will also, depending on what is going on with the disease outbreak, we also would work with communications to see about putting out information out to the community also. Yeah. Especially if we feel like we're still seeing it. So usually, typically, if we send out a HON alert, we're also putting something maybe out on a press release to also have the community be aware of it. So,
thank you.
Mm-hmm.
Commissioner Farr.
Thank you. Now I'm going to be very, very brief. This is a wonderful presentation. In fact, Nurse Sticka and Drs. Warren and Ludke and Director Gray, this may be the best presentation I've ever seen. And I'll tell you why I say that. Because just about every slide had a QR code on it, which allowed me to tap on it and get just a wealth of information. And that slideshow that you just presented is available to everybody who's by going to our today's agenda online. And there's a wealth of information there. So I'm not going to bore you with the questions I have. I can look it up. In fact, after Commissioner Buck asked about HON reports, I looked that up. And it says you can sign up for HON reports. I might just do that. So I wanted to mention that this is a great presentation. I wish everybody would follow your lead and put those QR codes, because each time you mention a website, typically I'm trying to type the website. Don't have to when you make that presentation. Chair, this is one of the best presentations I've seen. Thank you very much. And while it focused specifically on measles, it alerted us to all immunization efforts and the things that you're talking about a lot more than just measles by giving this report on measles today. Thank you.
Exactly. And I wanted to tie that together to say just one thing in particular about when we were talking about diseases. It isn't, for me, working in public health, it's a social issue too. It's not just somebody getting sick. It also has to do with the fact that it has an impact on people in our community, those that are affected when they don't realize that they've been exposed to that, people who are immunocompromised who can't get vaccinated, but also, you know, kids when they have to be isolated, the impact that that makes on our families that maybe are straddling the line and, you know, need to, you know, have something better in place for how it is that we look at infectious diseases. It's not just about the fact that they get sick. It has to do with the economic fact of it too.
Thank you.
Yeah.
And the amnesia, that's very alarming.
Yeah.
Thank you.
Commissioner Senega.
Yeah, well, between that, you actually answered part of my question. And a lot of it is almost just kind of a statement, and you made it at the very end, is why the hesitancy and understanding that. Because you can see by the graphs, it changes, it ebbs and flows. Well, it's a social thing. A lot of it is anti-vax. So not just saying this is what you need to do, but really breaking it down. Not everybody has an hour to sit here and listen to the whys. It makes sense to us now, but before this presentation, it didn't. And just one quick question. I'm just going to call it the SSPE. I don't want to try and say it again. That
I don't either.
Well, we know what we're talking about. Was that on a year? The cases, was that a year study? The 1 out of 100,000. You said we get how many cases a year?
I don't know for sure.
Okay.
So I'm not going to say yes when I don't know for sure. So I would have to look at it.
No No problem.
So, yeah, good question.
I appreciate it.
Dawson's disease.
Okay, great. Well, thank you. The takeaway, the TLDR is immunizations work, and they're really good, and we should do everything we can to make sure everyone who's eligible for them receives them on schedule. And I will just say the immunization work plan, I think I'm going to turn it over to Jocelyn to talk about frequency of coming back to us, but that's the kind of slide when I look at that I'm going to remember when you come back, that you're speaking to something you presented to us about all those different sort of pillars of the work plan to ensure as many people in our community are protected from communicable disease. So that's a really helpful slide. Thank you.
Thank you, Chair Trieger. Yeah, our proposal has to do with the cadence of these meetings. Just as a reminder, we met very frequently during the COVID response, and then we kind of rolled that back a little bit over time because we had a semi-annual report where we came to you in May and November typically to provide updates. And our proposal or our request is perhaps going into 2025. I met with Chair Trieger to discuss the possibility of kind of going back to that regular cadence of May to November. We, of course, would continue to bring issues to you that are emerging, public health issues or new projects too, and that does put me in mind that we will be requesting a special work session as well, probably in February or early spring, to talk about the Community Health Improvement Plan, which is the plan that really animates all of the work in Health and Human Services, is our foundational plan that is developed with the community. So we'll be bringing that back to you also for your input and feedback. We'll do that earlier in the year, but otherwise, we think that it would be best to for the cadence of these meetings. We've had some hiccups in scheduling with the quarterly sometimes, and then you have meetings that end up backing up to each other. So we thought that for the regular reports, May and November seem like semi-annually seem like a good kind of path forward now that we're more fully out of COVID.
Yeah, and I think when we discussed, of course, anytime there's an emergent issue, like when Dr. Lugke was here a couple of weeks ago about this mosquito, and so that's always on the table. So I think we're just sort of looking for general head nods unless there's any big opinions otherwise. Yeah, great. Okay.
Okay, well, great. Fantastic.
Thank you so much.
Thank you very much, Chair and Commissioners.
Thank you.
Thank you.
With that, we will move into item B with Health and Human Services, which is the order and resolution 24-11-05-04 in the matter of considering a resolution for presentation to the Oregon Legislature and the Governor, voicing support for the work of the Universal Health Plan Governance Board. And I'll welcome our Director of Health and Human Services, Eve Gray, to the table. And just a note to the administrator looking at time, probably we could do county administration and then flip human resources and the CJRS items, I think, if I'm tracking time properly, if this really takes up to
What do you suggest?
30 minutes.
Flip 8, 7, and 8?
Correct.
Yeah.
I think so. See how long this item takes
CJRS
after human resources, depending how long this item takes. Yep, thank you. Good morning.
Well, thank you all. Much of the points in my presentation were made very effectively already by the residents of Lane County who came and spoke to you, and really appreciate all of them bringing their voice to this topic. So what we're talking about today is a resolution in support of the work of the Universal Health Plan Governance Board. This is purposefully, distinctly not a resolution in support of a universal health plan for the state of Oregon, and that is because we don't yet have a proposal on the table for a universal health plan and what all would be included within that. So we're really talking conceptually right now, that we are asking for support of the work to create a universal health plan as an option to consider for the state of Oregon in order to improve the many challenges that we recognize exist within our healthcare system today. And also for Lane County and Health and Human Services in particular to be a voice at the table. So for background, many of the folks who spoke today are on the Universal Health Plan Governance Board or one of the subcommittees. I have also been appointed to a subcommittee, the Plan Design and Expenditure Subcommittee, really to give feedback as a provider agency about what a design of a plan and the expenditures, that meaning the payments to providers, how the design of that will impact the provider community in positive or potentially negative ways. So part of what this resolution does as well is give me the ability to speak on behalf of the county in those discussions, rather than speaking just as an individual who has experience as a healthcare administrator. So what are we really trying to solve here? The healthcare system in the United States today, in many places, is on the verge of collapse. And we've seen this in rural areas for years. It's now starting to hit us in metro areas as well. So for individuals, healthcare is incredibly costly. When you are diagnosed with a serious illness, I think many of us have experienced the thought of ourselves and our health and our future, but oh my gosh, how much is this going to cost? What's the impact going to be on my family when we have to pay for my healthcare bills instead of paying for rent or instead of paying to put food on the table? The thousands of dollars, even in a low deductible health plan, you're looking at thousands of dollars out of pocket maximum in a year in order to manage all of the copays and coinsurance and deductibles that exist before you get to a point where a great health plan will cover you fully. It is estimated that about 50% of bankruptcies in the United States have health care expenses as a component of that, as one of the reasons that the family fell into bankruptcy. So we're talking about access to care, quality care. I mean, we know that the United States of comparable industrialized countries has the lowest healthcare quality outcomes and the highest cost. So in comparison across the world, many of those comparison countries have a universal health plan as part of their healthcare system. And that is really what policymakers are drawing from to say, maybe that is something we should look at as a better option for us. The proposal that is being put forward would be that a universal health plan is financed through replacement of what employers pay today for health insurance. So employers would no longer be purchasing health insurance, but those dollars would be reallocated to a universal health plan, and then likely some form of a payroll tax. There is a finance committee that would figure out all the details of how this would come into play. Beyond that, though, beyond what you pay ongoing that you know is coming out of your paycheck, there would be no deductibles, no copays, no coinsurance, no additional out-of-pocket expenses. So in a year when you are diagnosed with cancer, you don't have to be worried about how your family's going to afford that expense. You can be focused on how you're going to get better, or at times how your family's going to transition to life without you, which is really what people should be focused on in this point of their lives when they have these major healthcare events that occur. But it's not just that healthcare isn't working for individuals in Oregon and in the U.S. broadly. Healthcare isn't working for employers. It was mentioned, healthcare expenses continue going up every year. It's a strain for companies. And you think about a company that wants to support hiring employees who have significant disabling conditions or who have significant health conditions. They are then penalized because now their health insurance risk pool looks worse. And the cost coming from their insured employees looks worse. So it impacts equity in all kinds of ways. It impacts equity in that individuals who have government-paying insurances have a harder time finding health care than those who have commercial insurance through their employer. And yet many people who end up on government-paid plans prior to Medicare age have something that prevented them from working for an employer that offered commercial insurance, whether that be a disabling condition or maybe it's just that childcare is more expensive than what they would receive in a minimum wage job with healthcare benefits. So we're really thinking about creating equity so that providers aren't trying to pick and choose which individuals they care for. And folks aren't trying to hold on to a job maybe when they're sick because that's their only access to health insurance. But just by being a resident of the state of Oregon, you receive coverage and you receive coverage that's equal. There is an exception in that the federal government is going to have to tell the state of Oregon how we can support Medicare beneficiaries. So I do want to kind of put that asterisk out here in the work is that given the federal rules associated with that plan, it is possible that Medicare beneficiaries would not have the same plan. But the Health Plan Governance Board is working on that and how they could provide as many services as possible to Medicare beneficiaries. So we've talked about individuals. The healthcare system isn't working for individuals. The healthcare system isn't working for employers. The healthcare system also isn't working for providers. Why are we seeing the privatization and the corporatization of healthcare? It is because the system is working exactly as it's designed. That we have expenses that are rising higher than revenues. We have an incredibly, incredibly complicated system where every single healthcare provider needs to contract individually with every single insurance company. They have to submit documentation for every single one of their doctors, nurse practitioners, physician associates to every insurance company who has to independently verify every time that that provider is licensed to practice in the state and is able to be contracted under their plan. All of the plans are different. They all have different quality measures associated with them. They all have different fee schedules and reimbursement rates. And you have to hire an army in order to figure out whether you're being paid what you're supposed to be paid. And then when you're denied the service because you made an error, you got to go back and chase the dollars. So in the initial plan that came forward from a task force that was looking at a universal health plan in the state of Oregon. This is the plan that ultimately led to the governance board being created. An independent actuarial firm came in and looked at the idea of a universal health plan. And what would that mean financially if we're not asking for out-of-pocket costs beyond our general funding of this system, and we're paying providers a living wage? So there's not, this is not Medicare for all, which panics healthcare providers because Medicare does not pay the bills. This is a universal health plan that is intended to pay the bills. Even with that, an independent actuarial firm said that the implementation of this plan would save the state of Oregon $1 billion a year. And where are those savings coming from? It's coming from getting rid of all of that really complicated administrative burden. That's about getting reimbursed for the service you provide, not about the care that we provide to patients in the state of Oregon. So that's the premise here. That is what the Universal Health Plan Governance Board has been asked to figure out, how to create a system where everyone could have access to the same health care that covered the same benefits, looking at basically what's covered by Medicare, Medicaid, and the Affordable Care Act today as the base plan, where providers can afford to continue to practice without having to rely on outside private equity or for-profit firms in order to lift them up and help them manage the administrative workload that exists, and ultimately lead to better health outcomes for Oregonians. That's what the Health Governance Board is trying to do, and we know that the devil's in the details, which is absolutely why today we're looking very high level at the promise of the plan and not at endorsing this as the solution to Oregon's healthcare challenges until we see what does that actual plan look like and what's all the feedback that's provided on it. So with that as kind of the basic foundation, I'm happy to entertain any questions at all in terms of what we are asking from you with the resolution that's before you today.
Thank you, Director Gray. To the board, questions, comments? Commissioner Farr.
You know, between the testimony this morning and your presentation just now, Director Gray, you've answered a lot of my questions. So I'm not going to ask a lot of the questions that I had before I came in this morning, but I'll express my support for the work of the board. One thing that you said at the very start, it's not a health plan, it's the board that we're talking about supporting today. And the last thing you said, the devil's in the detail. And that really is the issue, isn't it? Because how do we find all the providers that we need? We're having difficulty finding providers, licensed doctors and nurses today. So all of those answers will come as the board does its work, and I'm looking forward to the extensive work of the board. And I know that, let's see, is Mr. Swanson, are you still here?
No.
He left, but he's on the financial board. And you mentioned that the financial board is looking at how is this going to be paid for, and you also talked a little bit. There's a lot to talk about. How does this mesh with Medicare? Because we know Medicare is not a system that pays the bills, particularly. And Dr. Elder, you talked about mental health issues. We know that Medicare doesn't cover mental health issues anywhere near as well as it covers even physical health issues. Lots and lots of questions, but the work of the board will start to answer some of those questions. You know, the state of Oregon has a lot of lessons to learn as to how to administer large programs. We all know that from experience, but I'm excited about the work of the board. I'm excited about the members of the board who were here today, and I'm going to sign up for the updates as the board does its work, so thank you.
Thank you.
Comments, questions? Well, I will just appreciate you folding in the comments from this morning, but clarifying what this particular resolution is about and what it does, and for your willingness to serve, because I think it's an important and unique provider perspective to have county at the table because of our role as a primary provider as a local government. And so, you know, I think of that saying, right, if you're not at the table, you're on the menu. Like, we want to make sure that that unique provider perspective is there, because it is a system, and we are part of that system. So we want to be part of redesigning it, right? And I also just can't help but think about all the county services and therefore resource we spend in providing services that over a very long period of time, should we get to a place where we have a universal health plan, we would also realize savings. The number of people who need rental assistance or utility assistance that we provide because they weren't able to work or work full time because of a health condition that, had it been caught early or better managed, they might never have been in that position. I mean, the cascading effects of this, I think, over a long period of time, we can't even begin to imagine what that would look like, in addition to the sort of administrative nuts and bolts pieces that you've outlined. Is there any downside to us adopting this resolution today? I sure don't see one.
Not that I can think of.
Thank you. Great. Well, then with that, unless you have any other remarks you want to make, I would look for a motion.
Chair, I move to adopt and support the matter of considering a resolution for presentation to the Oregon Legislature and the Governor for the work of the Universal Health Plan Governance Board per Board Order 2411, 0504.
Thank you. Is there a second?
Allow me to second.
Great. It's been moved by Vice Chair and seconded by Commissioner Farr. Any discussion to the motion? Seeing none, all those in favor signify with an aye.
Aye.
Aye. Motion carries 5-0. Passage of Order and Resolution 24-11-05-04 in the matter of considering a resolution for presentation to the Oregon Legislature and the Governor voicing support for the work of the Universal Health Plan Governance Board.
Thank you.
Thank you so much. That concludes our business sitting jointly as the Board of Health and the Board of Commissioners, and we'll return to our regular Board of Commissioners agenda. And we do have time for the county administration items before we move into our 11 a.m. time certain. And so I will welcome Matt McCray, our County Recovery and Resilience Officer, to the table for discussion and action on a letter before us today. Good morning.
Thank you, Chair. Good morning, Chair, Vice Chair, Commissioners. I'm going to provide a very quick introduction to this just for those who are listening with us today. I know you're all familiar with the material, and then just provide some time to get feedback from you. So as you all know, Oregon Housing and Community Services is the state agency that is the recipient of $422 million to support wildfire recovery statewide, to support recovery from the 2020 wildfires, including the Holiday Farm fire that affected the McKenzie River Valley. OHCS provides HUD with an action plan describing how they intend to use those funds. And anytime there's any substantial change to the way they plan to use the funds, they need to provide HUD with a substantial action plan amendment describing the changes, and then HUD can approve or disapprove of those changes. When they make the when they provide that substantial action plan amendment, it gives us an opportunity to provide feedback on the proposed changes that OHCS is putting forward. So that is what you have before you here today, is a draft of feedback to go to Oregon Housing and Community Services. So I'm here today to get your feedback on this and take your direction on next steps. Thank you, Chair.
Thank you. Commissioners. Commissioner Buck.
Thank you, Chair. Thank you for the draft. We worked a little bit on it in advance of this meeting, and Matt, of course, worked on the bulk of it. Inside this draft letter, we are thanking them for a lot of the things that they're changing in the amendment per our requests over the past year or two. There's still a few things that we suggest, which are noted in the letter. But overall, I'm extremely pleased that they're moving in this direction and doing an action plan amendment. This is, as a reminder, for the $422 million in federal aid to all counties that were fire affected. So I would definitely support this and urge my board colleagues to support it. It's much better going in as a collective letter of the board rather than, just one commissioner's name on it.
Any other questions or comments from the board? I will just appreciate that comment. I agree. I think unless there's some advisement, and I see our policy director in the back of the room, having all 5 commissioners sign on to it rather than it coming from the board makes it very clear that we are unified in this and understand the importance of this. Is there any reason not to shift the structure of the signature that way? I think it presents a stronger message.
I agree, Chair. Thank you.
Yeah. Great. Any other questions or? Great. Okay. Well, then we don't have a motion, but we do have an action option. So, Vice Chair.
Chair, I move to approve the formal statement of feedback to the Oregon Housing and Community Services regarding the Oregon Draft Substantial Action Plan Amendment as presented.
I'll second.
And moved by the Vice Chair and seconded by Commissioner Buck. Is there any discussion to that motion? Seeing none, I'll ask for a vote. All those in favor signify with an aye. Aye.
Aye.
Motion carries 5-0 with the one change to putting all 5 commissioner signatures on the letter. Thank you very much.
Thank you, Chair.
Appreciate it. So with that, all the juggling of time, and let's get through county administrator updates and then see where we are with our 11 a.m. outside guests being present or not, and we maybe have an option to split the item.
Because our Community Justice Rehabilitation Services team is here, go ahead and take that. And then I was going to give an elections update, one other quick thing, so I can hold that for whenever it's.
So do we think we might be able to get through the whole item, or just stick with the time and see where we are when we get to 11?
Chair Trieger, we can go pretty quick, and it depends on your questions.
Okay, great.
Okay, thank you.
Thank you. Let's do it then. We will hear item 7, the Community Justice and Rehabilitation Services, and this is a presentation and also a board order before us in the matter of approving an application for the creation of an extended detention program in youth services. And I will have Director Rickoff introduce the panel, and thank you all for being here this morning, and to those of you that I've met and was able to attend the RISE presentation. So turn it over to you.
Chair Trieger, Commissioners, thank you very much for your time this morning. We're here to talk about extended detention. That is the state name and is what is in state law. Really and truly what we're here to talk about is secure treatment. I'm bringing a stellar team with me. I hope you've all had a chance at this point to meet Patty Robb, who of course is the principal manager. The rest of the state, in terms of the language of juvenile justice programs, would consider her to be the juvenile justice director, and I certainly see her as such. With us also is Kim McGrew. She is the CJRS manager and really serves as the assistant director, all focused on juvenile justice. We also have Peggy DeFazio. Peggy is our behavioral health supervisor and is, to some extent, the mastermind behind this work. And as always, we have Sarah Trulove here with us, who is, of course, my executive assistant and is going to be helping us with the PowerPoint, which looks like it's up. So this is the final step in gaining approval so that we can now go to the Youth Development of Oregon Board that will, which is the regulatory agency and makes the decision on county programs and whether or not we can do this. There were three things required of us in terms of gaining approval. The coming to the board was essential. It's also essential that the juvenile justice lead judge approve this. We do have a letter of support from Judge Love supporting this effort. We also went the extra step of ensuring that we had support from the Public Safety Coordinating Council, not necessarily required, but we thought it was a good thing in terms of overall exposure. So now that we are ready, here we are, and I'm going to turn it over to Patty for further comments.
Good morning. Thank you, Chair Trieger and Commissioners, for having us here today. We're very pleased to be here to present a quick presentation for you on the Youth Services RISE program. We appreciate the previous attendance you had at our 3 listening sessions this past summer. That was tremendous for turnout for all of you to be there to hear more about our program in detail and provide us valuable feedback that we could integrate into our planning. Today, I'd just like to give a brief summary of the program and where we're at as of today. The program is the Youth Services RISE program. Recovery, Integrated Stabilization, and Evaluation is what RISE stands for. The focus of this program is for adjudicated youth to be able to receive treatment in a secure setting so that we can address acute issues around mental health stabilization and substance addiction or fentanyl withdrawal. The program is designed to be a 16-bed co-ed extended detention program for up to 30 days. They are court-ordered youth, so every youth that goes into the program would have a review by a judge in the juvenile court who would then be ordering them into the program for a 30-day process where they would be assessed and receive a specific service plan to their needs. Following the 30-day extended detention program, they would then engage in an outpatient program, which would also be tailored to their specific needs. So our first slide is a summary of the program. All of the services that would be included include various screenings and assessment for mental health and substance abuse issues, behavioral health, medically assisted detoxification for youth who are coming into detention or the program under the influence of fentanyl or opioids that are experiencing withdrawal, as well as psychiatric medication consult and management, individual and group therapy, and neurofeedback therapy. All of the curriculums within the program would be evidence-informed practices, infusing youth and family voice into the curriculum, and ultimately building connection, belonging, and resilience, which is the goal of our services at Youth Services. Next slide. I did want to highlight again our partnerships in the community, which is a critical and essential component of the work that we will be doing. Cultural responsiveness is a cornerstone of the program. As I mentioned, connection, belonging, and resilience, which are all achieved through the cultural partnerships. So we have a lot of partnerships and engagement in the process this past summer and going forward. Oversight of the program would be through Youth Development of Oregon, which is a state agency. They would be coming in and providing the guidance and an audit of program services. As we mentioned, we do have a letter of support from the court and as well as support from the PSCC. And we're here today to hopefully obtain that same approval from all of you. We are also actively engaged countywide through education resources through ESD, and that is also a strong component of our program, as each youth that goes through the extended detention program would be assessed for educational needs, and then upon leaving the program, they would also be reintegrated either into the MLK education program or directly back into their districts. Next slide. The why of our program, our purpose, really is to increase resiliency, improve inclusion and belonging, reduce systematic disparity, reduce recidivism, reduce mental health symptoms among our youth and families, and reduce state commitments. Last year, we committed approximately 88 youth to the Oregon Youth Authority, and one of our primary focus in developing this program is to reduce the number of youth that we are committing to the state for treatment purposes or incarceration, and to retain those youth locally so that we can keep them integrated with their families and community resources and meet their needs here locally. This is going to create a shift in skills and knowledge for our staff, and we're deeply dedicated to investing in our staff going forward for the training and delivery of services needed for the specialized care of youth that are in custody and also in the community following 30-day detention. There's a very strong family model in that we are including parents, guardians, or recognized adults that are supportive of youth while they're going through the extended detention program in detention, and also when they rejoin the community and return home or to a setting in the community, that we will have adults, parents, and guardians as part of the model for youth being successful in the community. We also are having a strong connection to medication-assisted treatment for youth who are withdrawing, recognizing that 30 days may just be a start in the withdrawal process for withdrawal from opioids and treatment, and developing a process for them to continue in those services once they do leave the 30-day extended program. As I did mention, education is also a large component of that connection and reconnection, and making that a priority as youth transition from extended detention as well. Our next slide. This slide may look familiar as it was discussed in our listening sessions, but to summarize, this is for youth aged 12 to 18 who were adjudicated and who are in need of stabilization services. The program does include screenings, evaluation, and risk assessments specific to the youth in that age group who are involved in the juvenile justice system. Treatment modalities include individual, group, and family treatment, medication management, and neurofeedback. There is a wide variety of curriculum infused into all of those treatments based on the needs of the youth, their families, and the dynamics specific to the family unit as a whole. Aftercare will include a specific service plan or treatment plan if that is what is needed. There will be a weekly a multi-team that will look at the issues for the youth while they're in extended detention, and that group will continue to meet a team unique to the youth's needs and who all is involved in their lives to continue to talk about what does that youth and their family need and how can we continue to support them in being stable in our community. We are also going to, once Oregon Health Authority develops in-home skills guidelines, we plan to expand the program to include in-home skills to support youth once they do transition to their homes with their families, so that we're delivering and supporting services in the home to youth and their families. Next slide. One of the great components of our program are the measurable outcomes that we plan to have in place. We do plan to have regular data that we want to provide updates on to show the effectiveness of what we have in plan and have in place. The skills curriculum will include such activities as structure of intellect, which is based on developmental abilities, Thrive by 25, which is brain health related and mindfulness skills. Treatment curriculum will be based on seeking safety, neurofeedback, and different types of treatment, as I mentioned, unique to the youth and family needs. We will also be using evidence-based tools that are recognized federally and by the state to measure data specific to resilience, service plan goals, and treatment plan goals, including neurofeedback data. And also, this will be aligned with the goals set aside for performance-based standards, which is a national standard recognized for the way that we do work in the juvenile justice system and the standards we intend to meet. Phoenix Strong is our outpatient program, and again, this will be a core component of youth that aligns with the program. Once they leave the program, we intend for them that day upon leaving to connect with our outpatient services for a unique plan tailor-made to them and the unique dynamics of their family, which could include individual, group therapy, parent education, substance outpatient, or support groups. One of the things that we're very happy to do is that something such as substance abuse outpatient could be tailor-made for families or several individuals within the family versus one individual in the family. So we're taking a very strong family approach to services that we provide. The last slide, revenue impacts. I did want to talk about revenue. It is a financial risk as we're moving into a new program, and that is always something we want to consider. But this is also a business necessity in how we are doing our work and making an effective program that truly is driven by improving lives. We are looking at reducing system dependence, which overall will then reduce costs and need to serve others. And we want to improve community connection and belonging. Ultimately, the amount of revenue we're looking to replace is around $450,000 annually. We believe it will essentially be a wash if we look at a very conservative model of only serving around 20 youth annually. That would be a quarter of the youth that we are currently committing to Oregon Youth Authority. So we believe that that's a very realistic model as a bare minimum, and we do anticipate actually generating revenue from the service. Our current timeline and hope is to submit our application to Youth Development of Oregon in December. And if accepted, to move forward, we would then be looking at having a site review in January.
Thank you. Chair, at this point, we'll turn it back over to the commissioners.
Great, thank you so much. Appreciate the presentation and your flexibility on the fly with timing today. Thank you for that as well. To the board, Commissioner Buck.
Thank you, Chair. So from what I'm gathering, this replaces the Phoenix program or alters it? I'm just trying to figure out what the difference between the two is.
Yes, so the Phoenix program was community-based, and it does replace that program as of now. We do have a plan in place to assess what are our residential needs for youth. We still do have that building in place and able to be used for approximately 20 treatment beds. But right now we recognize extended detention as our most immediate need for youth who are in crisis and needing stabilization. we were not able to do that work in a community-based setting.
And if I may, the difference really is the Phoenix-based program was voluntary, and when the going got tough, a lot of young people left. And what this gives is, with the court determination of the individual serving, we'll have them for the full 30 days, which gets them through some of the hardest days in treatment.
So are the beds at Serbu or in a different location since it's no longer in the same building?
The beds remain on campus, so it allows us to open another area of our detention facility, which is referred to as secure treatment. So the RISE program would sit within secure treatment, which is where we're focusing on treatment services in detention. So we do have those 16 beds available that still provide treatment services.
So the building where the Phoenix program is at will have to be reimagined as this progresses.
It has, and we are currently utilizing that for outpatient services, which is a new area that we have developed to support youth in the community and coming out of detention. So part of the building is still in use, and the other part of the building will need to be reimagined.
Thank you.
Commissioner Farr.
Thank you, Chair. Good question, Commissioner Buck. You know, we always think about where is additional money going to come from, and what does it displace, and will it displace anything, or will it ultimately be self-sufficient in terms of its funding? I don't know we're answering all of these questions with the presentation today, but I have a couple of questions surrounding that. One, and you might have covered this, and it went right over my head, the levy. How does the levy fit into this, the provision for youth services that is in the levy, the sheriff's levy?
The levy continues to support the program the same as it would if it were a community-based program. Additionally, we have the Medicaid waiver 1115 coming, which allows us to open new revenue for billing for services in detention.
They say it's coming.
They say it's coming, yes.
Okay, good. And I was going to ask about the 1115 waiver to see how that's going to mesh in. So that's kind of our hope on the horizon, more or less. Then regarding billable services, that's ties in with the 1115 waiver, and you're estimating 25,000 in billable services. Do you expect that's going to go up significantly? Should we begin getting the waiver?
We should, and we are planning. We're currently participating in the readiness assessment with Oregon Health Authority to be one of the first counties that moves forward in the process.
Well, I admire the work that's being done on this tremendously. It's forward-thinking, and it's actually providing services. And Gregory, if you mentioned that the Phoenix program, the issue with that is that a few days into the program, the youth in that program there's no reason for them to not walk if they don't want to walk. This is it's radically, it's completely different in that the entire 30-day treatment period will be uncounted. What happens after 30 days, well, we'll talk about that, because we know that 30 days quite often is not enough, and that services need to be continued. And hopefully in that first 30 days, the value of the services is realized by the person receiving the services and by their immediate support system outside of the judicial system. So I think you're answering all my questions. You're answering my questions with questions, but questions that I had. So, I think, once again, I admire the work that's going into this. I admire it tremendously. Thank you.
Thank you, Commissioner.
Vice Chair.
Thank you, Chair. Yeah, just going through the experience, I think the 30-day mark is a really great mark, because typically we only had 2 weeks, and 2 weeks was absolutely the bare minimum of just to try to make a change, but 30 days gives us enough time, so I think that's great. I love the fact that you've got the families involved in the model on trying to get the youth back into the community where they belong, under the covering where they're, accustomed to, and you're also looking at the needs of the family and helping those services too. So I think it's a great plan. I'm fully in support of it, and I think that your bare minimum bar, I think you'll probably exceed that, and with this 1115, I think we're onto something very good. So appreciate all your good work, people. Thank you.
Thank you.
Just real quick, you started off with the perfect point. 88 youth we commit to the state each year. I mean, that's when it really hits home. So great work, appreciate it.
Thank you.
My only question is one of timing from submission of the application to when we hear, and whether there's, that's a procedural. This isn't a competitive grant kind of thing. This is an application saying we are ready to implement the program. Here's our credentials. Here's our plan, right, to the youth. it's to the state youth, I'm going to get the,
Development of Oregon.
say again?
Youth Development of
Youth
Oregon.
Development Oregon. So what are we anticipating is the timeline, and is there anything in that interim that we can do to support the application, or is it just a procedural application?
The timeline we hope is, within 30 to 60 days after the site review, but we are really vulnerable to whatever the committee decides. They'll review all of our policies, procedures, and our setting, and let us know, do we need to develop more areas? Are we ready to go? So it really depends on what that audit and review reveals for us.
Great, so it is just, make sure I'm really, it's a sort of procedural, are you really ready to implement the program? It's not competitive, there's not a dollar amount in question, it's just.
Correct.
Great, thank you. That was the only question I had. Great. Seeing nothing else, any other remarks or anyone else on the panel want to weigh in? Director Rickoff, nothing else? Okay, great.
Done the order.
Okay, we do have an order before us on this application, so I'll look for a motion.
Chair, I move in the matter of approving an application for the creation of an extended detention program in youth services and delegating authority to the county administrator or their designee to submit the application and to sign the contract per Board Order 24110505.
Thank you. Is there a second?
I'll second.
Thank you. It's been moved by the Vice Chair and seconded by Commissioner Buck. Is there any discussion to the motion? Seeing none, I'll call for the vote. All those in favor, please signify with an aye. Aye. Motion carries 5-0. Approval of Order 24-11-05-05 in the matter of approving an application for the creation of an extended detention program in youth services as presented. Thank you all so much, and waiting to hear back. I hope it's a swift and efficient process to getting the approval. Thank you.
Thank you so much for your support.
And so here we are, it's 10:58 and ready for our 11 a.m. time certain. And again, thank you to everybody for all the maneuvering and adjusting of time. And so this is item 8, and it is Human Resources. And I'll welcome our Director of Human Resources, Alana Holmes, to the table to introduce her panel. But we have before us 5 board orders to consider, all in the matter of adjusting the base annual compensation for Lane County elected officials. Good morning, Ms. Holmes.
Good morning, Chair, Commissioners. Alana Holmes here with Human Resources to discuss recommendations from the Elected Officials Comp Board. And basically, I wanted to go ahead and introduce both Eliza Kaczynski, who is our Senior Analyst in Classification and Compensation, and she is the one who continuously staffs the EOCB. And then with us today is Penny Doherty, who is a member of the EOCB, the Elected Officials Comp Board, and she has graciously provided her time today to lead us through the presentation, which will then allow the board to ask questions before moving forward with the orders that are attached to the memo. So if you don't have any questions for me, I'd like to turn it over to Ms. Doherty.
Thank you, Alana, and thank you for the opportunity to be here this morning and present. As Alana said, the EOCB is a 5-member citizen board. Is that better? I couldn't tell sitting in the back. I really couldn't hear a thing, so. We're charged under state law with reviewing elected officials' compensation on a yearly basis and providing recommendations to the Budget Committee and the board. Consistent with the Lane County Manual and the EOCB bylaws, in reviewing elected officials' compensation, the EOCB considers compensation paid to persons comparably employed in Oregon, the number of employees supervised, the size of the budget administered, the duties and responsibilities of the elected officer, and the compensation paid to the officer's subordinates. Just as kind of a way to ground where we come from, our focus is to review, in our review, is to recommend compensation that is competitive, allowing Lane County to attract and retain highly qualified individuals in these very important elected positions. The EOCB makes its recommendation to the Budget Committee, who then makes a recommendation to the Board of Commissioners for final approval. Compensation following the EOCB review in 2023, compensation adjustments were approved for all elected officials. the assessor, district attorney, justice of the peace, and sheriff all received compensation adjustments effective in July of 2023. Consistent with the Lane County Charter, the Board of Commissioners are scheduled to receive in January of 2025 the market adjustment that was approved last year. I know you all are aware of that. In terms of the 2024 review, EOCB met 2 times in May and June of 2024. We reviewed total compensation of Lane County officials in comparison to comparably employed persons in Lane County's 5 comparator counties. Those are Clackamas, Deschutes, Jackson, Marion, and Washington. The same used by HR in evaluating employee compensation. Importantly, total comp for purposes of our review includes not just base salary, but also the value of benefits such as health insurance and retirement contributions and stipends. For Lane County employees, the county typically targets compensation to be within plus or minus 5% of the comparator average. In this year's review, we found that the sheriff, the justice of the peace, the district attorney, and the assessor are all within 5% of the average of the comparator's compensation. For the commissioners, EOCB considered the compensation that commissioners will be earning after the adjustment scheduled for January 2025 in its analysis. The commissioners' January 2025 compensation is 10% below the comparator average, putting their compensation on the brink of being misaligned. We also reviewed compensation for compression against direct reports. Compression is when the salary range for a direct report is very close to or more than that of their supervisor. The sheriff is experiencing compression with his highest paid direct report, and after the direct report receives their next step increase, will actually be making less than the direct report. Under Oregon law, the sheriff must make more than their highest paid direct report. So following our review, the EOCB recommendations in 2024, EOCB recommended a 2% cost of living adjustment for all elected officials, as well as a compression adjustment for the sheriff and a market adjustment for the commissioners. A 2% COLA is consistent with the COLA provided to the bargaining units that had contracts in place at the time the recommendation was produced. The EOCB recommended a roughly 6.62% compression adjustment for the sheriff to ensure that his compensation remains above that of his highest paid direct report, even after scheduled adjustments to the direct report's compensation. The EOCB recommended a roughly 3% market adjustment for the commissioners, in addition to the previously approved adjustment, in order to bring the commissioner's salary within 5% of the comparator average. In terms of effective date, EOCB recommended that changes for the assessor, district attorney, justice of the peace, and sheriff be retroactive to the first day of the first pay period after July 1, 2024. Lane Charter limits the effective date for compensation adjustments for commissioners. Those have to occur after a general election. Therefore, the changes recommended for commissioners could not, under the charter, be effective until the first day of the first pay period after January 1, 2025. Turning to the Budget Committee action, the Budget Committee met on October 7th and voted to recommend, 1, a roughly 2% cost of living adjustment for the assessor, district attorney, justice of the peace, and sheriff. 2, a compression adjustment for the sheriff. And the Budget Committee voted that there should be no additional adjustments for the commissioners. More details of the EOCB's recommendation are included in the packet that was provided to you previously. The board orders before you today reflect the recommendations of the EOCB as voted on by the Budget Committee. The board has the option to approve all some or none of those adjustments, or to adjust compensation by a different amount. So that is really the total of my presentation to you. Do you have any questions for me or for the wonderful staff support that we received from Eliza?
Thank you so much for the presentation to the board. Commissioner Farr.
Thank you. Thanks for a great presentation. I'm wondering, is your presentation actually in the body of today's packet, or can that be added to the body of the packet? Because you went into great detail as to the chronological events that got us to this morning.
And so the question is, can
we have a copy of that beyond the recorded text?
Chair, Commissioner Farr, we'll work with staff to make that happen.
I would love to be able to have that in text form so I can present it to people who have questions, because there will be questions surrounding this. And I think you've given us a great detail regarding market conditions, regarding compression conditions, and regarding cost of living based upon the consumer price indexes. And you've also mentioned that this Board of Commissioners, as a part of the Budget Committee, has rejected 2 pay increases that your commission suggested, a 2% COLA and a 3% market adjustment. That's, the board doesn't always take recommendations of the committees. The committees make recommendations based upon their best work, and the board takes the recommendations or refuses the recommendations based upon our best work. So well done. I apologize for us not taking your recommendations, but I think each of us has different reasons for saying no on this particular recommendation, and I'm in favor of the work that you did. Continue the good work. It seems thankless sometimes, I know, and I've talked to other members of your board, and you keep your chin up, you keep working, and time after time the Board of Commissioners says no to your recommendations. But we have 5 of them in front of us that we will take action on today. So, Ms. Doherty, thank you very much for all the work that you put in. And this is statutory work, I understand. You're required to perform this work and make the recommendation to the Budget Committee, and which subsequently comes to the Board of Commissioners. Thank you.
Any other questions or comments? Seeing none, then we do have a series of orders before us, so I will look for motions.
Chair, I move to approve in the matter of adjusting of the base annual compensation of the Lane County's elected assessor per Board Order 24110506.
Thank you. Is there a second?
I'll second.
Thank you. It's been moved by the Vice Chair and seconded by Commissioner Buck. Is there any discussion to the motion? Seeing none, I'll call for the vote. All those in favor, please signify with an aye.
Aye.
Aye. Motion carries 5-0. Approval of Order 24-11-05-06 in the matter of adjusting the base annual compensation of Lane County's elected assessor. Next item.
Chair, I move to approve in the matter of the adjustment to the base annual compensation of Lane County's elected district attorney per Board Order 24110507.
Is there a second? Second. Thank you. It's been moved by the Vice Chair and seconded by Commissioner Buck. Any discussion to this motion? Seeing none, I'll call for the vote. All those in favor, please signify with an aye.
Aye.
Aye. Motion carries 5-0. Approval of Order 24-11-05-07 in the matter of adjusting the base annual compensation of Lane County's elected district attorney.
Chair, I move to approve in the matter of adjusting the base annual compensation of Lane County's elected Justice of the Peace per Board Order 24110508.
Thank you. Is there a second?
Second.
Moved by Vice Chair and seconded by Commissioner Buck. Any discussion to this motion? Seeing none, I'll call for the vote. All those in favor, please signify with an aye.
Aye.
Aye. Motion carries 5-0. Approval of Order 24-11-05-08 in the matter of adjusting the base annual compensation of Lane County's elected Justice of the Peace. Next item.
Chair, I move to approve in the matter of providing a cost of living compensation adjustment to the Lane County's elected sheriff per Board Order 24110509.
Thank you. Moved by Vice Chair, seconded by Commissioner Buck. Any discussion to this motion? Seeing none, I'll call for the vote. All those in favor, please signify with an aye.
Aye.
Aye. Motion carries 5-0. Approval of Order 24-11-05-09 in the matter of providing a cost of living compensation adjustment to Lane County's elected sheriff. And finally,
Chair, I move to approve in the matter of addressing salary compression for the base annual compensation of Lane County's elected sheriff per Board Order 24110510.
thank you. It's been moved by the Vice Chair and seconded by Commissioner Buck. Any discussion on this motion? Seeing none, I'll call for the vote. All those in favor, please signify with an aye.
Aye.
Aye. Motion carries 5-0, and that is approval of Order 24-11-05-10 in the matter of addressing salary compression for the base annual compensation of Lane County's elected sheriff. Thank you all. Thank you so much, and to the rest of the Elected Officials Compensation Board for providing your time and your expertise to inform us and to help Lane County with this really important role that we play. We appreciate you very much.
You're very welcome, and I will pass that on to other members of the board.
Thank you. And thank you, as always, to our staff for all the support they provide the committee. Thank you. Then, before we recess for lunch, we will go back to item 6B, which is county administration announcements. And we have an elections update and any other announcements from our administrator this morning that he has to share.
Thank you, Chair, Commissioners, good morning.
Today.
Brief update for you. Today is, I don't know if you noticed this, today's election day.
I heard that.
It is E-0, so here we are. As of yesterday, a total of 160,823 ballots have been returned, representing a 58% turnout of registered voters in Lane County. We're passing around stickers. I voted stickers, so if you voted already, hopefully you voted, turned in your ballot already, please take a sticker. Registered voters that have not yet turned in their ballot are encouraged to do so as early as possible today. Long lines are expected. I can tell you, long line yesterday outside of elections that wrapped around onto Lincoln. So a lot of folks turning in ballots yesterday. We expect long lines today. So you can return your ballots at ballot drop sites and at the clerk's office at 275 West 10th Avenue in Eugene. Ballots returned by mail must be postmarked by today. Those can be received through next Tuesday, November 12th. They're received by next Tuesday, November 12th, and postmarked by today, then they will be processed and counted. They're not postmarked today. They're postmarked after today, and if they're received after November 12th, they will not be. For those using a Dropbox site, please remember that when the clock strikes 8, it's too late. Drop your ballot off by 7:59, and it's just fine. Isn't that a nice, fun little rhyme we have? I'll be actually at the clerk's office tonight volunteering, as a number of our team here in Lane County will be volunteering and assisting. And again, you can drop it off by 7:59, it's good, but once the clock strikes 8, it's in the past week, the clerk and elections team has hosted numerous in-person observers and conducted multiple tours during the active ballot processing cycle. I understand that all 5 commissioners have toured elections in the last week or so. Several of you have already done that, but it took the time to do it again, some for maybe the first time. So appreciate, commissioners, that all of you have taken the time to do that. Initial election results will be posted to the website at 8 p.m. tonight, and then updated again at 11 p.m. Additional updates will be posted tomorrow, November 6th by 5 p.m., and Friday, November 8th by 5 p.m. So tonight, election night, at 8 p.m. and 11 p.m., November 6th by 5 p.m., and November 8th by 5 p.m. And then the full elections results posting schedule, a list of the 21 ballot drop boxes in the county, the ballot return dashboard, the live stream link, and all other useful information can be found at Lane County Elections website, lanecountyor.gov/elections. As I mentioned, I'll be volunteering. We have a number of staff in Lane County that are volunteering. We have elections workers. Anyone who is an election worker, volunteering or paid election workers, we do a swearing in process to affirm each individual's commitment to uphold the integrity of the elections process. This is required under Oregon revised statutes. So I will tonight be sworn in, as we do for all of our, this is a very important process that we do for all elections workers. We even deputize a handful of individuals that are more intimately involved in the signature verification process that we have. So it's a very, I also just share that we continue to hear really positive feedback from the community. Just everywhere our teams are going, great appreciation for the transparency, for the information that's available online, the webcasts, the updates. That's what we want, is for people to trust this process, to know what's happening, when it's happening, how it's happening, and to be able to trust that process. So that's all the information I have on elections, unless you have any questions. We will provide an update again next Tuesday, November 12th. Questions?
Commissioner.
So the way it was explained to me too, Mr. Mokrzycki, is if you're in line at 7:59, you're fine, right? So there can be a line of 10 cars at a ballot drop box if you're in line at 7:59.
Yes, if you're in line.
So nobody's rushing or elbowing to get in the ballot box, but if you're there present.
Yes.
Yeah.
And we will have folks working at the drop box sites, you know, to make sure who's in line and cut that line off by 7:59:59. Any other questions there?
Any other questions or comments from commissioners? Great. Well,
one other comment I wanted to make about Veterans Day. Veterans Day is coming up here in the next week, and I just wanted to recognize that we have in Lane County 67 veterans among our employees that work here. In employees that range from our Health and Human Services Department, our Sheriff's Office, Public Works, Human Resources, the DA's Office, County Administration, Assessment and Taxation, Technology Services, and Community Justice Rehabilitation Services. We have veterans that are active duty. We have service medal and active duty veterans. We have Armed Forces Service Medal veterans. We have recently separated veterans and other categories of veterans as Lane County employees. So we want to thank our employees who are veterans in Lane County, and certainly the residents in our community who are veterans, and recognize those who served our country in that way as Veterans Day comes up here in the next week. So I want to make a note of that, Chair. Thank you. That's all.
thank you so much. That concludes our business for the morning. So at the sound of my gavel, we'll be recessed and then back here in Harris Hall at 1:30 for a relatively brief human resources item, and then we will recess to transition up to the conference room for the remainder of our day this afternoon. We are recessed.